Good evening, everyone, or is it afternoon? Thank you very much for Dr. Connolly and his team for inviting me to this conference, and Kathy for chairing the session. She is my mentor, and I can see quite a number of people in this room who are making me get scared to speak, like Frank Ferries and his team, because they emphasize a lot on public speaking, which was quite difficult for me. But I'm very happy to be here this evening, and I'm hoping that I'll be able to share with you the model we're using in Kenya. I realized that most of the presenters this morning talked about a lot about statistics, which I don't want to go through. I don't want to mention because I'll be repeating what has been said this morning. But I'll briefly look at maybe hospice and palliative care services in Africa, and Kenya is an example mainly because I come from Kenya and wanted to share really about what you're doing in Kenya. And then maybe just a few recommendations which people can learn from as well. Again, like I said, people talked about the disease burden in Africa. I highlighted Kenya because some time back I was sitting to a very top level executive for a big pharmaceutical company, and he asked me which country I was coming from. I said I come from Kenya. And he said, is Kenya in Egypt? So I put Kenya in yellow because we are not in Egypt, we are a country in Africa. That's where Kenya is. So we know about the disease burden in sub-Saharan Africa. I'll not go into those details. I think Joan, Stephen, Emmanuel talked a lot about that. I'll just go to maybe Kenya. Kenya is we have a population of about 44 million people in Kenya. And of these 44 million people in Kenya, we actually don't have a cancer registry in my country. We have one that just looks at 2 specific regions of the country. So it's not very accurate. But we estimate about, last week, just before I sent this presentation, the Minister of Health said 40,000 people develop cancer every year. New cases of cancer, that is, we don't know what the prevalence is. And of these, probably about 30 or 38,000, if it's 40 now, die within the first or 2 years of the disease. This is because of late diagnosis, not necessarily late presentation, but because it's we don't have enough resources for treating cancer. We have only one public hospital with 2 radiotherapy machines. One is broken, the other one is always breaking down, and it has been a lot in the news. So we have patients who are going to for radiotherapy treatment, and they're told to come in 2018. These are patients with advanced disease. Of course, they will not make it for 2018. And HIV/AIDS remains a big problem in our country, about 5.8% prevalence. And non-communicable diseases, again, are very high. About 60% of hospital beds are actually full of people with non-communicable diseases. So you see, as everybody has been saying, actually we are a low, sometimes middle-income country where the need is high. We have the least resources, like many other countries as well. So again, access to palliative care still remains a challenge for most of our patients. And a survey that was done some time back found that only 45% of countries 45% of the countries in Africa had no palliative care at all. Although this is changing slightly because we have areas of palliative care that are coming up in most of the African countries. And so the key indicators for palliative care that people usually talk about, one of them is access to opioids. And sometimes I always think, okay, so access to opioids, but sometimes you can provide palliative care even if you don't have opioids. I know pain management is a key component of palliative care, but where you can do things like counseling, talking to the patient, breaking bad news, those are also very important components of palliative care. So sometimes we tend to focus a lot on pain management. I'm sorry, Jim, but sometimes we have to look at everything else that is involved in palliative care for patients. Again, only a few countries have palliative care integrated into the national policy, and I just learned that there are new countries this morning from Dr. Manuel. I think he's mentioned Tanzania, Rwanda, Zambia, Malawi, Mozambique, and I think the main countries that have national palliative care policies. Other countries are in the process of developing palliative care policies. For example, Kenya, Uganda, South Africa are in the process, and Botswana, I think, are in the process of developing palliative care policies. But you find that we have captured palliative care in other strategies or frameworks within the country in many other ways, like I'll show in a while. So it doesn't really, sometimes we start from the top to bottom, depending on what we are looking for, what you want to do, or sometimes from bottom to top. And for us in Kenya, we actually started with trying to integrate palliative care into the hospitals and other systems before we started addressing the issue of a national policy. So in Kenya, for example, palliative care is provided by hospices where they exist, and the first palliative care services in Africa mainly were actually through hospices. As Dr. Anne Merriman would tell you, they started through freestanding hospices, and I think we have great champions here. I think there's Dr. Anne Merriman, there's Liz Guida, who have done a lot in South Africa, Liz, and Dr. Anne Merriman in Uganda, who can talk a lot about the services they provide. We also have palliative care provided by public hospitals in most of the, in quite a number of the countries in Kenya, not all of them. And then we have the mission hospitals, because sometimes you forget the role of the mission hospitals. But in Kenya, where I come from, most patients will end up in the mission hospitals because this is where they can get, they will be sure there's going to be medicines, the medicines will be available, and the services are also cheap. And we have mission hospitals in the most remote, most difficult to get to places in Kenya. So they are also very key in providing palliative care. We have a few private hospitals that are providing palliative care, especially the ones which have got cancer treatment centers. And then we have the community-based organizations. And again, I think we're trying to really focus a lot on the community, and it has come out a lot this morning. The community is very important in providing palliative care. So we are trying to look at all those levels where we can actually have palliative care integrated. So for our hospices in Kenya, and I think in most of the countries in Africa, they provide outpatient facilities. Inpatient facilities are very few. In Kenya, we have only 2 hospices that have got beds, because it's quite expensive to run an inpatient facility. And most of these hospices are freestanding. They have to do their own fundraising. And again, in the previous session, we talked about patients who might need to be admitted in a hospice or a hospital. And I know most people think that people in Africa don't need to be admitted because the family is always there and everything. But I think it's very important that we also recognize sometimes a patient is too sick to be at home. Like Emmanuel said, I've seen patients who are bleeding and the family is so frightened of the sight of blood and the children don't know what to do. So it's also important to understand that we need to have a place where some of these patients can go to when they're sick. And that's why the integration of palliative care into hospital is important, because they can stay in the hospital and still receive the palliative care services in the hospital. And hospices also do home visits and pain management and symptom management, counseling, and all those services that we know, training and bereavement services as well. For us, what I wanted to share mainly today was the model that we're using in Kenya of integrating palliative care into the public healthcare system. This is something we started working on in 2010, and it really was a lot of advocacy at the government level, going to the Ministry of Health and talking about palliative care many times, and trying to convince the ministry that we needed to have palliative care as any other service in the hospital. When people go to the hospital, they should be able to still receive their palliative care services, to have access to morphine, just like when they go to the hospital, antenatal clinic, or any other clinic. This should also be a service that is available to anybody who needs it. So it has been a bit tough, but I want to really recognize our government, because they have done a lot of goodwill. And one of the things that happened is that we had 2 ministers of health. One was the Minister of Public Health, and one was the Minister of Medical Services. The Minister for Medical Services was a male minister, and he got prostate cancer. And then the Minister for Public Health was a female minister, and she got breast cancer. And I know this is not a good thing, but it really opened their eyes to the needs of patients. They were lucky they were able to go to the US. The government paid for them to get the treatment, but they came back. We went to them and told them, what about those patients who cannot go to the US? Where can they get their services? So they really, that's why we started having them as champions to advocate for palliative care. And our current Minister of Health is also very supportive, talks about palliative care all the time, and has actually promised to put a line budget for palliative care for government hospitals. So that has been a very positive move for palliative care in our country. And the reason why we are focusing a lot on integrating palliative care into government hospitals is because we don't need to start building a hospice or another structure. There's already an existing structure in place. So when we put palliative care into this structure, we use the resources in those hospitals. The nurses are trained, the doctors are trained, the social workers, and the patients are within the hospital. And the challenge, of course, has been we have had to look for funding to do the training. When the government will write a a circular and say, go and work with these government hospitals and integrate palliative care, but there's no money to do the training. And it has been very expensive, but I really want to say thank you to our donors because they have supported us to go and train. I think for each of the first 11 hospitals we worked with, we trained about 20 people in each of the hospitals, multidisciplinary teams in each of the hospitals. And now we started actually with the two referral national hospitals, then we went to what we call the provincial hospitals, and now we are doing the county hospitals. So we have about 50 hospitals in Kenya that have integrated palliative care. Like I said, it is easier when you work with the government existing structures and you bring palliative care closer to the patients. Otherwise, they would have to travel long distances. It's time, it's money, they're sick. So all these things really work for the good of the patient. That's what we are doing in Kenya. So if you look at these maps, there's one that shows where the hospices are, and there's the other one that shows where the government hospitals are. What has happened is some of these hospices are within the government hospital facilities because the government has hosted them, and some of the government hospitals have no hospice near them. So where there's a hospice and a government hospital existing together, we have tried to work to make these two work together. One of the challenges was that the hospices that had been there before the hospitals were not really willing to work with the hospitals. There was the issue of you're stealing our patients, you're going to steal our funding, but it has taken time for them to realize it's at the end of the day, it's about the patient. The hospital takes care of the patient in the hospital, and when they're discharged, they go they are discharged through the hospice, where the hospice can actually follow them at home. And the hospices have been actually great mentors for these hospitals because they have been in existence for a longer period. So you find they will join the hospital team to do ward rounds and identify patients who need palliative care and need to be followed up in the community. So it's actually it had a lot of challenges, but it's now working very well in Kenya. So for the hospital palliative care units, like I said, we have units in the hospital where we have most of them have a nurse as a leader, and again, like Dr. Manuel said, mostly it's the nurses who are giving more of their time and efforts to patients who need palliative care. You find that the hospital team, the palliative care hospital team, will do ward rounds with the other members of the team, and they are also the teaching team because most people have not been taught about palliative care either as nurses or doctors. So the team that we have been training actually goes around in the ward rounds and teaches the doctors and other professionals how to identify patients in pain, how to assess pain, how to treat pain, how to titrate morphine, and it's just really empowering the nurse to be the voice for the patient. They also run outpatient clinics. They might have daycare services, not very frequent because they are costly. They also, some hospitals, a few of them have been lucky to have a car donated to their service, to their unit, or some of them will use the hospital ambulance to go and visit patients at home. And so again, like I said, the collaboration between hospices is very important with the hospitals in terms of continuum of care for the patient. One of the other things we have invested in is training the hospital teams. We have the champions in the hospital. We have trained them, not just in palliative care, but we also train them to be trainers. So they are now the trainers because we realize that if you want to empower people, you have to really not just teach them how to take care of the patients, but they also need to understand how to teach others. So we have courses that are going on in Kenya, which we introduced about 3 years ago, a diploma in palliative care, and other short courses. These students can actually go to these hospitals and be mentored by the palliative care teams in the hospitals. So again, mentorship and supervision have been part of the program that we are doing, where either the hospice is mentoring the hospital. Where there's no hospice, we actually go there and do the mentorship ourselves. So this is working very well. This is just a team. This is a palliative care unit, one of the hospitals that we are working with, Machakos, and a patient in the hospital that is receiving palliative care. Again, integrating palliative care into different policies. We don't have a standalone national policy. We are working on that. There's already a draft that's ready. But we have integrated palliative care in all the other documents that are important and strategies. So we have palliative care in the National Cancer Control Strategy as one of the pillars in the strategy. We also have national palliative care guidelines, which have included palliative care, pain management for both children and adults. And we have also developed national palliative care guidelines that have actually been adopted by, all these documents have been adopted by the government, Ministry of Health, and our WHO country offices. So they are actually very strong documents when they have those two logos on them. We also recently launched a national strategy for the prevention and control of non-communicable diseases that has also included palliative care. And this actually has also a component of training the community health workers on palliative care. So it's also, we haven't started rolling it out, but we're going to start rolling it out very soon. Again, other documents that we've worked on are training curricula for medical students, undergraduate medical students, and also the nursing curricula. The core curriculum for the doctors and nurses have also included palliative care. And it was just recently that we started working on the content for medical students. Then one for nurses, we had done it, but the one for doctors, there was a bit of confusion. So we just recently submitted the content for, and I want to say I borrowed a lot from the AIIHPC curriculum for training medical students, so that has also been very useful. So we did a project with the Tropical Health Education Trust, and Dr. Scott, Moira, and Julia here were part of the team. We focused on a few things when we're looking at this kind of model. We focused on advocacy, service delivery, staff capacity, and partnership and mentorship. I'll just finish that very quickly. And so advocacy, really, it's at all levels of care, whether it's at all levels, whether it's national, public, community, patient, different people talking about palliative care, and mostly patients talking about it has made a difference in Kenya. Last week we had so many, we had a lot of coverage because of the World Hospice and Palliative Care Week, where even the media visited the prisons to talk about people in the prison who need palliative care. So actually advocacy at all levels is very important. And again, getting your government people being involved, like we have our former Prime Minister laying foundation for a hospice, and then again staff capacity building, which is very important, training of doctors, pharmacists, nurses, health, social workers, and even the community health workers as well. This is just a letter from the Ministry of Health for a partnership to strengthen the partnership and to help to work with the government to integrate palliative care into the public healthcare system. And I also want to talk about the national association's role. The national associations are very important. Where there's a national association, actually they can take up the lead. Because most times when you go to the government, they are too busy to do some of these things. But if they give you the okay to do it, then you actually have we move around with these circulars from the Ministry of Health, and they carry a lot of power. So we can go into any government hostel and work with them. And one of the things the government has done actually is given us a doctor, secondary doctor to our association to work with us, so that we have easy access to all government facilities. Morphine, again, in 2010 we had a stock out of morphine, but now we have a lot of morphine in the country that is being brought by the government for the government hospitals. We are working on a central manufacturing like Uganda, to have one place where you can have the morphine manufactured or rather morphine consumed and then send out to the rest of the government. So there are many challenges. I won't talk about them. I think all of us have mentioned the same challenges: funding, training, and training is very important. We have to train at all levels. We have to talk about it to the public and everybody else for them to understand it. We have our own challenges because we just developed into a county system. That has been a challenge, but we are hoping that will actually work out soon. So making palliative care everyone's business is very important, and that's, I think, was the theme last year for World Hospice and Palliative Care, because if it's not everybody's business, then we're just going to be wasting our time talking about it. One thing I know that has worked for us is going with a solution and not just a problem. When you go with a solution and say, we will train your people, we will help set up units, we'll do this and that, then there's a lot of positive and goodwill from the governments, and you know, the political will actually changes. But when you go blaming the government, why don't you have palliative care, why are you not doing, you waste your time. You really have to be friends with them, and beg your donors to give you the money to go. So if you go there, you say, I have this amount of money, I am going to train this people, I'm going to set up a unit. That really works very well. And so I just want to say thank you to so many people who have put a lot of efforts in making palliative care available to many people in Kenya. Thank you.